are now entering the Pain Pod, sponsored by the Chronic Pain Association of Canada. Are you ready to know what you don't know about chronic pain? We're shining a light on the good, the bad, and the very ugly about living with pain in Canada. No hype, no hysteria, just the truth. And now, here's your host, Anne-Marie Gatto.
Welcome back, Pain Potters. It's nice to be here again. We haven't been together for a long time now, I know, and so much has gone on. It's actually quite a bittersweet day here for me because, as you know, I've been hosting the Pain Pod for several years now. And as you also know, the Chronic Pain Association of Canada has come to an end, completely outside of our control, but it was an organic ending, I guess, nonetheless. It does make me sad. I am, however, excited to share our last podcast with you, a guest I've been waiting for a long time to interview. So I'm really excited to share this experience with you. And I'm going to get this right. So I'm going to be reading off my script here. And I'm going to introduce Dr. Ashley Gerard, who is a naturopathic doctor in Ontario and a graduate of the 4-year doctorate program from the Canadian College of Naturopathic Medicine. She is a member of both the Ontario and Canadian Associations of Naturopathic Doctors and an associate member of the Canadian Urological Association. No small feat. Dr. Gerard is the owner of Holistic Bladder Care, a telemedicine-based practice with a focus on female bladder and pelvic conditions that stem from her own struggles with recurrent UTIs and bladder pain syndrome. Every patient is treated according to their unique presentation that respects their beliefs and empowers them to solve their health concerns. She collaborates with practitioners globally in order to help patients access effective treatment options with the goal of achieving a better quality of life with these conditions. She has additional training on hormone balance, digestive issues, thyroid diseases, and other chronic pain conditions. Dr. Gerard is passionate about educating her patients, finding the root cause of disease, and inspiring change that leads to healing. So let me give a big warm welcome and thank you for joining us today, Dr. Gerard. It's so nice to have you.
Thank you, Anne. It's lovely to be here today.
Good. I have a little bit of a cold. I think she may have a little bit more of a cold, but we're going to get through this nonetheless. Mm-hmm. So we're going to dive right in because there is never enough information on female pelvic chronic pain conditions. There isn't. I've been dealing with this since I was 19, which is decades ago. And basically, in the medical world, I'm getting the same information as I did when I was 19, which is shocking, but this is the way it is. So Dr. Gerard has another more holistic approach to these conditions. So I'm just going to dive right in and ask, okay, standard urine and vaginal swabs are missing infections. What does this even mean?
Yeah, so this being my practice focus, this is what I spend a lot of time educating patients around and helping patients get better answers for. So, I suppose we have to start a little bit at the beginning, where a lot of patients who listen to your podcast are patients that are struggling with chronic pain conditions. And that, unfortunately, there are times where patients have those conditions, but they may have other contributing problems they may have underlying infections. It really is kind of the crux of the problem, and why I'm here and speaking with you today is that, unfortunately, our standard testing can misidentify or not identify, I should say, infections. And then patients end up in the chronic pain world, and ultimately they don't get treatment for a potential infection, and they end up, doing pain management for long periods of time, because that's the only option that they're given. So So,
Not to mention the
yeah.
unimaginable suffering with an underlying infection that
Mhm.
no one has found or no one has treated, and it just keeps brewing month after month, year after year.
Yeah. And some infections, they don't necessarily escalate. Some infections we get stuck with them at lower levels, and they don't create that big acute typical UTI that we see in some patients. So unfortunately, there are patients who just have lower grade infections that they're stuck with, and because of our testing and the issues around our testing, it never gets identified. So they stay they start to get diagnosed with interstitial cystitis, bladder pain syndrome, vulvodynia, various other pelvic related pain conditions, and ultimately a large portion of their symptoms, maybe not all at that point, and we'll talk about that further down, but oftentimes a significant portion of their, or all, if it's earlier in the scheme of this problem, right? If it hasn't gone on for years and years, sometimes even still adequately treating that infection can sometimes give a patient immense relief, to the point where everyone starts to get to question, did I ever have that previous diagnosis, right?
Right.
So the most important thing to start with, a big portion of my practice is UTI patients. And those, again, a big portion of my practice is patients. Oh, my apologies. I'm going to turn that onto
That's
mute.
okay.
That was my plan. It didn't happen right at the beginning, though.
That's
Okay.
quite all right.
So, um, so UTIs is the biggest portion of my practice. That's what I went through. And then by extension, it has moved into some of the vaginal infections as well. So I will touch on that, but more so on chronic bladder pain and the infections related to that. So
Mm.
let's just start with, you wake up one day and you think you have a UTI, and you go to the doctor's office and you get the standard urine culture. And unfortunately, the standard urine culture comes back negative. So this is a big portion of my patients. They get negative standard urine cultures. Eventually, a doctor will some doctors will still treat them with antibiotics, and then they get better. They're kind of the lucky ones. Their doctor was treating based on suspicion, based on the acute onset, but then other doctors insist on waiting for that urine culture to come back positive. And if it doesn't, then they won't give an antibiotic. So this happens a significant portion of the time as well. And patients never even get the opportunity to see if an antibiotic would have helped them.
Right.
So,
And it has to be the correct antibiotic,
yes,
because I've had that happen to me as well before. I'm one of those people who've had these underlying infections, but they would give me the standard antibiotic, which was not, which would not have been the appropriate antibiotic for if that had cultured. And I think, don't quote me, but I'm pretty sure that urinalysis is more than 70 years old now that we're using,
yes,
that everyone is using.
yes,
Yeah.
yeah. So we're going to talk all about that. So so when you go to your doctor's office with the symptoms of an infection, a urinary tract infection, you get offered usually a urinalysis, which we like to call the urine dipstick test, which they'll sometimes do in office, sometimes not. Sometimes they'll send the sample to the lab. And also, so the urinalysis and the standard urine culture. So the urine culture is what actually grows the bacteria. The urinalysis is meant to check for white blood cells, blood, something called nitrites to see which is produced by certain bacteria, your urine pH, how hydrated you are. So the two tests together are usually what makes a diagnosis for a UTI for most doctors. But unfortunately, the standard urine culture, the rates of a missed infection are 30 to 50%, and it was designed in the 1950s. And it actually was never designed for UTIs in the first place. So it was originally designed for detecting kidney infections. So it was never validated for lower urinary tract infections. So that's where, if we use it for kidney infections, we have about an 80% accuracy, which is acceptable in the world of testing. But with this decreased accuracy down to 50%, that's not a good test, and we rely on that. It is, and so a lot of the researchers who are on the forefront of this problem, a lot of them completely want to throw the standard urine culture in the garbage. It's leaving way too many women with infections potentially not properly treated. Now the benefits, if you do get a positive, it is very useful. I always still recommend my patients to go and get the standard urine culture at the first sign of symptoms, just in case, even if they've had negative cultures every time in the past. It's just good practice, because every now and then we get one that comes positive, and if we can grow it on the regular medium in the lab, then we can do the sensitivities to be more confident which antibiotic works. So it's not, we don't want to throw the baby out with the bathwater, but we certainly don't want to rely on it to make all of our treatment decisions.
Mm-hmm. Mm-hmm. Do you think that there's reasonable hope on the horizon that we will sooner than later have an updated, incredibly more accurate urine test?
Well, we do have more accurate urine tests now, but whether or not how quickly they'll come to Canada is the main question. So other countries do already have more advanced testing, but even within their guidelines for using them, they're slow. It's been slow to adopt those particular new testing types. So actually, we did have really big news in the American Urology Association. They did just last month update their recurrent UTI guidelines to include the more advanced urine testing types as a diagnostic aid for understanding their patients' infections. So that's the first time that the advanced urine testing has been brought into a standard of practice. So that's big, that's very big for that particular type of testing. Everything, right? When it comes to new testing, there is many additional tests that have to be done to validate for that specific condition, and that takes time. There has to be enough evidence, and then eventually standards of practice change. Usually in the US, things change more quickly compared to here as well. So although the American Urology Association has added it, I don't anticipate the Canadian will do so immediately. It will probably take some time. So
that's frustrating.
But at least somebody has. So
that's frustrating.
It is very frustrating.
So when the standard tests fail, either misidentify something or don't identify it at all, what are some of the things that folks are getting diagnosed with?
Well, that's if we get numerous tests negative, and a patient, maybe they were never given an antibiotic, maybe they were given the wrong antibiotic, so their symptoms never improved. Usually at that point, a patient is then referred to a urologist, and unfortunately, that often will result in a diagnosis of interstitial cystitis and bladder pain syndrome. So there isn't really too many other diagnoses that help that you can turn around and look at for if you have urgency, frequency, and bladder pain. There isn't too many other things that doctors will look at. Endometriosis is one to always consider, but your urologist won't look at that either, right? And you need to have other symptoms associated with your menstrual cycle to be able to start thinking that might be what's causing those bladder symptoms.
Is there a definitive test for endometriosis? Or is it, again, a diagnosis of exclusion or something along those lines?
There is a laparoscopic analysis of the abdominal cavity, of the pelvic cavity, is the gold standard for diagnosis. There are some imaging techniques, if they're done by a certain specialist, those are very helpful as well. But I want to go back to talking about the testing a little bit more.
Sure.
I want patients to have be equipped with some of the other statistics to be aware of with the testing. So the urinalysis, I want to jump back to that one because that's the one that's looking for white blood cells in your urine. And I did want to make sure your listeners were aware that that's only 30% accurate. So even worse than the standard urine culture. So a lot of patients will be told, well, there's no white blood cells. That means that there's not an infection. But the problem with that particular measure is that if the urine sample sits for very long, then the white blood cells degrade. So by the time by the time you've peed in that cup and you've taken that to the lab has taken it to a main lab where it's then analyzed, that they can degrade and it will appear like there aren't any white blood cells. Same with the standard urine culture. So both the standard urine culture and the urinalysis also have been identified as having too high of a threshold to say something is positive as well. So there are patients who do have bacteria or white blood cells in their samples, but they're at a lower amount. And therefore they're told that they're negative because it's basically a yes or a no for the testing here. So that's also something that is a struggle for patients. The other part is that as soon as you get a UTI, you start drinking lots of water. So you're diluting, right? You're doing a lot of dilution. And that
or if you think you have a UTI, you start drinking and drinking.
That's what I mean. Yeah.
Yeah, like if you think or if you do, you start pounding back water and maybe marshmallow root tea or something like that to try to help yourself.
Yeah.
Yeah.
So that's a problem as well. So there's also that there are some organisms that just don't grow on the standard urine culture. So E. coli is the most common. Yeah. The standard urine culture was designed to grow E. coli. So of course that's what it picks up most of the time. There are numerous pathogens that don't grow on the standard urine culture very well or at all. Some require a longer incubation time. The standard urine culture is just a 24 to 48 hour incubation. So some bacteria need 3 to 5 days to grow. But by that time, the lab has thrown the plate out and you're told you have nothing going on.
Right. Or I believe if they give you antibiotics, it's going to be for E. coli. Even if that's not even known or that's not even what you have, that's what you'll get. The prescription will come out as some sort of standard E. coli antibiotic.
Yes. Yeah, that is true. I will say that a lot of the standard UTI medications do work on a good variety of both. E. coli is what we call a gram-negative. A lot of them do work on gram-positive as well. The nitrofurantoin or macrobid, fosfomycin has activity against both. Bactrim is the one that, or sulfamethoxyl trimethoprim, also called Bactrim or Septra. That one really is very specific to E. coli and gram-negative bacteria. So that's the one if patients tell me I was given this antibiotic, it didn't work, but then I was given one of the other ones and it did work, I'm usually suspecting a gram-positive of some kind that was not originally detected in their urine culture. So it's really important to know the bacteria and what the different UTI medications can do in order to be that detective to figure out what might be missing. And then, of course, there are some pathogens that cause urethritis, so it looks like a UTI as well. And they don't grow on the standard urine culture, and they need very specific antibiotics that would never be offered for an acute UTI. So,
right. Oh, this is so distressing because I am no stranger to this. I've been through all of this over the, I've been in these trenches for decades, and I've had all of these things and more happen to me. And I just know how devastating this is on your health, whether it's the illness part, especially the pain part. I can't tell you how disabling and devastating this can be. And then to be told, oh, we can't find anything wrong with you, so you must have bladder pain syndrome, and away you go, there's nothing we can do. And if you're lucky, you'll get pain meds, but not likely today. So
not today.
Yeah.
Yes. Yeah. And then you're told, please wait 3 to 6 months for a specialist. And even at now, I think that's generous. Most patients are waiting far longer this day and age compared to what maybe you and I waited a decade ago for a specialist.
Absolutely. Absolutely.
Mm-hmm.
Oh, my goodness.
Yeah. So the other part of this too is that if you have, so back maybe 10, 15, 20 years ago, it was less common to have more than one bacteria in your urine for a UTI, but that's actually becoming more common as time goes on. So,
No.
so when a patient gets a report back that says contamination suspected, that actually might not be contamination. That could be that there was multiple organisms in the sample and it was thrown out for that reason. So that's another issue. Pardon me.
That's okay. I remember too, once upon a time, hopefully nobody believes this now, but once upon a time, all doctors were told and believed that urine was sterile,
Yes, that's
that there
on.
was nothing in there. It was sterile, which is because it's, I always thought of it as like liquid waste. How could that be sterile?
Mm-hmm. Yeah. Yeah, it's really interesting what the biome projects around the world have brought, but we find bacteria everywhere. Brain, inside of organs. I mean, the bladder being an empty organ, it makes perfect sense there would be a biome in the bladder as well. It's much less diverse compared to the gut, but pretty much we have more bacteria than we have in our bodies than we have cells of our own. Bacteria are much smaller. So there's more of them actually than there are of our own cells.
That's fascinating.
Mm-hmm.
That's
So
fascinating. So patients then get labeled as a chronic pain person, a person in pain,
yeah.
and those therapies, if there are any, might be offered to you. Um, and this may not be the case at all. This may not be the case at all.
Mm-hmm.
So,
Yeah. So this is a lot of the work that I do in accessing that better testing. Um, there is something called EQUAC testing for urine, which is an expanded urine test. So grow it for longer on more different mediums, larger amounts of urine. So that can sometimes help identify a pathogen. We also have what's called PCR testing. PCR looks for very specific segments of DNA, which we have a high confidence that if we find that in your urine, we know that bacteria is there. PCR testing only identifies a certain number. It's usually it could be between 10 and 20 different species. So some species are still missed, unfortunately. But if we find it, we know it's there, which is very
okay,
useful.
now those two methods of testing, I'm going to just assume here these are not available through your regular medical practitioner. They wouldn't
No.
have access to these, and this would be something that maybe might go through you, but there's a company somewhere doing these tests.
Yes. Yeah. A lot of these are self order available for patients. A family doctor can order them, but many are uncomfortable with using new technology.
Or might not even know about it as well.
Mm-hmm.
Yeah.
Yeah. And I mean, it is important that we have a good amount of evidence to start using new testing. But at the same time, if a patient is stuck in chronic pain because of it and not getting adequate treatment, we also have to weigh those pros and cons of having robust data. I mean, we have lots of data, but in order for standards to change in Canada, we require a very high level of certainty that testing is going to be useful for patients. The other problem is that this testing tends to be very expensive, which is
Right. And
hard on patients.
this high level, etc., is completely ironic because I know in my life that standard 70-plus-year-old urinalysis has been completely useless at times and to the point of being dangerous. So we were talking about the urinalysis and the failure for it to pick up a lot of these urine infections. There's also other infections that go misdiagnosed or undiagnosed in the way of vaginal swabs. Can you talk a bit about those testing measures?
Yeah, so because UTIs often have that additional uh, comorbidity is having vaginal infections as well. This is something that's come into my practice just by treating UTIs over the years. And unfortunately, vaginal swabs aren't a whole lot better. Often when you go into your doctor's office and you've got, say you've got burning after urination, which can be actually from a vaginal infection, or just burning all throughout there, they will often pair the UTI test with a vaginal swab. And unfortunately, that one only checks for yeast and bacterial vaginosis. So, and when we say yeast, we're talking about specifically Candida albicans, which is one
Oh,
type of yeast.
yeah,
So
one type, one type.
one
Oh,
type, yeah. So unfortunately, there are many types of Candida that are not checked by the standard vaginal swab. And there are other vaginal infections like ureaplasma, um, trichomoniasis, that are not, or other types of rare yeast that are not tested for on the standard swab. So if you get a standard swab, oh, everything's fine, totally normal, right? And then, but you have symptoms, and it's very confusing for patients. But patients aren't told that it doesn't cover everything. It doesn't check for everything. The other issue is bacterial vaginosis. This particular test is like the standard urine culture test. It has a high threshold in order to report a positive. And unfortunately, that means that there's quite a few women who have levels slightly below that are told that they're fine. They don't have BV, but they do have an elevated amount of those bacteria in there, or not in their vaginal canal. So not a great test either. There's potentially up to the sensitivity of that test could be as low as 37 to 50%. So that means a significant number of cases are missed. And with the advanced testing that's now available, that is something I find quite regularly, is patients who they don't have full-blown BV symptoms. And I mean, full-blown BV symptoms are usually a fishy, smelly discharge, gray discharge, vaginal inflammation, burning with urination. A lot of women don't have that full set of symptoms, but they might have a couple of them.
okay.
And then they don't get that diagnosis. So
So,
really,
it's interesting because if you don't know to ask questions and you're a woman having these burning symptoms or pain, what have you, and they go and they do this swab and they say, there's nothing there, you're fine, but you don't even know they've only tested for one type of yeast and a large threshold of BV. You don't even know that. So you're just under the assumption that if there was anything there at all, they'd find it.
yeah,
Not
exactly.
true. Not
And
true.
that's one of the reasons whenever I have a new patient enter my practice, I'm always it's in my intake forms, it's in my first email. I want to see your test results. I want to see what they say. I want to analyze them myself and see what was actually done, and and make my own so I can make my full recommendations. So um, that's something that patients are usually told everything's fine, and and maybe they haven't had, maybe they just had a urinalysis, they didn't have a culture, maybe maybe they didn't even have a vaginal swab, maybe they got a pap. So
Right.
yeah, well, they did a pelvic exam, they did something, and it's like, okay, well, let's make sure they checked the things that they were supposed to check. So so yeah, it can be really challenging getting urogenital infections as a woman and getting accurate information from those tests.
Well, it
The
sounds like the actual investigative measures are so minimal, or they have such a high opportunity to be incorrect.
Yeah,
So,
yeah,
I mean, you're between a rock and a hard place. If you don't, if you're not trained in these matters, you're just going to believe exactly what else would you believe?
yeah,
You
and
know,
it
they
of
say,
course,
okay, you have this chronic pain. There's nothing we can do. You're just going to have to find a way to live with it. And
yeah, and it of course results in a lot of anxiety for patients.
oh my
Patients,
goodness, yes.
as you know, women come in and they say, I know I know I feel this pain, I know I feel this burning, I know something is wrong, but all my
Mhm.
tests are negative. It's extremely frustrating and anxiety provoking for women when they don't get adequate testing and then treatment for what's actually going on. So yeah, so a lot of my practice is about educating, about helping patients understand the better testing, potentially accessing them so that they can get those better answers, and then treatment and the reassurance part of this where, we just need this medication. We need to make sure that after the antibiotic that is selected, that you have a healthy biome left to protect you, because that's often at the crux of this in the first place, is that our vaginal biome is much richer in bacteria compared to the urinary biome. It's
Okay.
our first line of defense. It is supposed to be very well populated with specific lactobacilli species, and when we don't have those species there to protect us, that's when, and those lactobacilli species, they produce lots of acid
Right.
that is able to kill off lots of uropathogens and vaginal pathogens and keep the system healthy. And those lactobacilli move over into the urinary system. So that's what a healthy bladder biome typically consists of, is lots of lactobacilli species.
So, if you actually knew that your vaginal swabs were not comprehensive and you wanted to have something comprehensive, is there another way to go?
Well, we have the patients can look up the testing, but we want to select urine PCR tests, urine NGS testing. NGS stands for next generation sequencing testing, for both urine and vaginal potentially. And then we also have some other testing. um, the We have what's called third generation nanopore sequencing, which is basically looking at the entire genome of basically all the DNA in the sample. So there's more advanced testing that patients can access, and I mean, not that I'm affiliated with any particular company, but in the US we have Cirrus DX, we have Microgen DX, we have Juno Bio, we have Evi. In the UK, we have digital microbiology and Focus UTI testing. So there are other countries that are spearheading this and have offerings. So patients can look at those different options, and unfortunately, like I said, they're expensive and they are one point in time. So sometimes patients need multiple tests to help understand things. But after, like I said, once it's identified, that can very significantly help lead patients to the correct antibiotic to use for their particular case. But really, recovering from chronic infections requires restoring the biome afterwards. And different antibiotics have different impacts on the vaginal biome. So when I'm screening patients for developing recurrent infections, one of the questions I'm always looking for is, did they use amoxicillin, or did they use it a lot as a kid? Because amoxicillin is really good at killing lactobacilli, and clindamycin as well, which is often used for dental procedures. So those two antibiotics in particular really decrease vaginal bacteria, and in some cases completely strip the vaginal canal of good bacteria. And then whatever grows is whatever grows after that. And that may not be protective.
A lot of us have been given ciprofloxacin 500 times in our lives. How does that one fare?
That one can decrease lactobacilli, but certain species. So not a total decimation of the vaginal biome, but could. It depends on the species you have of lactobacilli in that situation.
Okay.
Mm-hmm.
So it's very interesting. So we have many biomes in our body, not just a gut biome. Like most of us have heard of a gut biome, but we've got a urinary biome and we have a vaginal biome, a gut biome, probably others as well.
Mm-hmm. Yeah, exactly. I think even some of the newer research with dementia is looking at the biome and how dementia rates are impacted by the gut biome. Yeah, so really, really interesting stuff. But going back to patients who end up in this situation, obviously getting diagnosed with something that is a chronic pain condition that's incurable, that is a recognized disability, creates a lot of panic and anxiety, changes,
Depression.
life-altering plans, right? When I was going through this myself, I questioned, would I be able to be an ND someday? Would I be able to have a family? Would I be able to work? It just completely throws you for a loop. And on top of that, of course, you're dealing with chronic pain every day, and trying to manage. So and then waiting as long as what we have to wait is really a disservice to women, right? And unfortunately, when we get to the specialist's office, a lot of them don't specialize in in women's urology, or urogenital infections. Urology is a surgical specialty that they
Right.
are.
That's right. They're surgeons. That's right. Yeah.
So dealing with infections is not always their main focus. And unfortunately, when we look at even the guidelines for interstitial cystitis bladder pain syndrome, uh, we don't have very good options, do we, Anne? Right? I have it, the most recent ones printed out here, and lots of highlighting. And I mean, our only oral medication had a 25% rate of causing a rare type of macular degeneration and is no longer recommended. And then all the like installations into the bladder, Botox, um, injections into the pelvic floor, all of them have not robust research to show any certain cocktail is the way to go. Really
No,
mixed.
there's never been anything with any great deal of efficacy. There just hasn't been.
And there's
And
such
a
a
lot of times these things cause more problems than before you even had it. So,
yeah,
like for an example, if maybe you're prescribed bladder installations, so a certain medicine cocktail will be inserted into the bladder, which might not do anything, might not. You don't know until you try.
might not.
However, once you insert that catheter, your chances of getting a UTI go right up.
Yes.
So you can end up, in a worse situation than you were before.
Yeah.
And yeah, and it's not. I don't just following along with the general literature and what have you. I don't see a lot of difference between when I was 19 and now myself at 60. When I look at the reports from the big support groups in the United States, like there's nothing new or novel or anything that's come out to treat these chronic conditions. And I wonder if one day many of these patients will be, figured out that they have such and such an infection that was never found, or perhaps an infection we don't even know about right now.
Mm-hmm. Yeah, and that's it's the hard part is that, unfortunately, if you have an infection that isn't treated for long periods of time, it will eventually start to cause tissue damage in the
Yeah.
bladder, right?
Yeah.
It will unfortunately lead to reduced bladder capacity because of scar tissue. And this isn't the only organ that we see this with. We see this in the digestive tract as well. If patients have longer term infections that are not treated, scar tissue is formed. And once scar tissue is formed, scar tissue is formed. Like we can't really, we can maybe make it more pliable, more elastic over time, but scar tissue has replaced healthy tissue. So unfortunately, that's one thing, that a feature of interstitial cystitis bladder pain syndrome is reduced bladder capacity. A normal woman per void has around 300 mils per void and goes about 6 times a day. If you unfortunately do have this particular condition, your void volumes go down to potentially average of 100 mils a day.
Mm-hmm.
And many women report going to the bathroom on average 15 to 25 a day, times a day, and that's extremely disruptive. And most of these women have this sense of urgency the whole time in between their very short windows where they're not going to the bathroom. And the ability to travel and do the things you love and work, and sleep and be intimate with your partner, everything is disrupted. So it leads to a really high a really significant lower quality of life, which may have been able to be prevented if we had identified the infection causing the inflammation in the first place.
To begin with.
And this doesn't happen to everybody either. I had a patient who had been diagnosed with ICBPS not long ago, and she had been suffering on and off at a lower grade for about 10 years, but some periods of time were good. This is quite frequently reported in patients with this problem, right? Is that, a couple years of good, maybe a few years of bad, or months, weeks, it can be all over the place. And just to kind of tie everything in, our body can sometimes get over infections. Sometimes our immune system finally get the upper hand because maybe our stress is low, we're sleeping better for a period of time, and then spontaneous remission can sometimes just happen. So that's in a lot of patients' stories as well, when you hear a lot of stories. Anyways, this particular patient, she had been suffering for a couple of years, and she had leukocytes in her urine frequently when I reviewed her testing. And we went on to look at some of the advanced testing, and she was found to have ureaplasma in fairly high levels, which is even right in the IC standards. If a patient has leukocytes in their urine ongoing on multiple tests and standard.
Now, those are white blood cells?
Pardon?
Those are white blood cells, leukocytes?
Yes. Yeah. White blood cells.
If they have them ongoing.
Yes. And then we should be testing for these rare species. And she turned out to have one of them. And treatment with the right antibiotic, it was a few weeks, and symptoms completely went back down to normal. So having it for a few years still is not necessarily not going to cause life-altering issues, but 10, 20 years potentially. It depends. It depends on the pathogen that patients get and how it interacts with the body and the amount of it that they've had. But definitely, if a patient reports that they felt a lot better from being on an antibiotic, say it was an antibiotic given for a different reason, and this comes up a lot in patients, right? This is their clue. They took they were diagnosed with this condition, and then they took an antibiotic for some other reason, and their symptoms became very quiet, right? It's something to pay attention to.
Oh, absolutely. So let's wrap this up here. I'm going to ask you, what is HRT and how does this fit into this whole subject?
Yes. Okay. So we also have to talk about estrogen and its effect on women. So as we go into menopause, our estrogen levels decline. Mm-hmm. And even before menopause, perimenopause, we see an estrogen decline in this period for some women as well. And unfortunately, women start to develop vaginal dryness, UTIs, and in more advanced cases, we actually start to see disappearing of vaginal tissue, vulvar tissue, labias, clitorises. The estrogen keeps those tissues plump and healthy. So we have very good evidence that UTIs are significantly reduced with vaginal estrogen. Vaginal dryness is addressed as well. That progression towards atrophy starts to significantly stops in most cases, and even in some cases can be reversed. It depends on how long that atrophy how far it's progressed and how long it's been left untreated, and a significant decrease in UTIs and getting infections. The most important thing to understand is that what happens is estrogen, we think of our vaginal canal like, a tube, right?
Yeah.
But really, when we look under the microscope, there's all kinds of little folds of all kinds of the vaginal wall, tiny, tiny little folds. And in those folds and at the cellular level, lots of the lactobacilli stick on there. So when we get atrophy, we lose all those tiny little folds. We call them rugae. We lose those. So there's much less surface area for the lactobacilli to grow on. So we get lower levels. Okay. And like I said before, if we have lower levels of lactobacilli, we get more UTIs because there's not enough.
So the estrogen is actually helping your biome.
Yes. Exactly.
Which is
Yeah,
what we need to be healthy in order to be infection free.
exactly.
We can.
So
Okay.
really important that when women start to get even in perimenopause, if vaginal dryness is starting, actually even, I mean, oral contraceptive pill, losing your eating disorders, losing your period. There's lots of reasons women can develop vaginal dryness, but that is one of your first signs that your biome is in trouble and that we need, or taking a certain antibiotic, right? And we need to pay attention to that. So but for the purposes of UTI rates going up in menopause, this is usually the culprit, is that women need vaginal estrogen. So this is actually in the UTI guidelines, which is great. But even women that get diagnosed with IC-BPS, a portion of those women also respond really well to estrogen therapy, vaginal or systemic potentially, because those receptors in the vagina actually are also in the bladder. So the bladder has full of estrogen receptors too. So it thickens the lining, it makes it more resilient to infection, to the contents of our urine irritating the bladder wall. So twofold benefit potentially for even patients who are in chronic pain. Something to consider if they don't have any of the, like, estrogen has been vilified for quite a while, but a lot of that research has been backed
It
off,
was.
as you know.
Yeah. Yeah. And
So
I mean, I don't mind telling anyone, like, I started on systemic, so my estrogen is in the form of a patch. It just gets stuck on your skin, and without that, my bladder is just a burning ball of hell. Like there's no way to compare with or without. It is so bad without that HRT. Then you add the HRT and it's like, oh, I can manage with this, you know?
yeah,
It's
yeah,
not always burning, you know? I don't have to go to the washroom 60 times every day. Like it's a whole different life because the organ itself is so much happier that
much
I
more
can cope
resilient.
with this. This isn't, this is something where I might need help once in a while, but not like that disabling, devastating, non-stop 24/7 burning, where you basically cannot even stay out of the washroom. It's not that anymore. So I am someone who has been ever so grateful to have, had the opportunity to use HRT
Yeah.
for very medical reasons. Like I wasn't looking for it for hot flashes or anything like that. It was strictly for my urinary health, and it worked, and it does
Yeah.
work now.
Yeah, it's if anyone is if any of your listeners are worried about HRT,
Mm.
topical is much safer than oral, and bioidentical is we're getting that research that shows it's superior to the older forms of HRT with conjugated um, equine estrogens. And I always encourage patients to read the book Estrogen Matters, which is a summary of the more recent research since the Women's Health Initiative that outlines the problems with the Women's Health Initiative and the research since then that has been able to resolve some of those issues. Um, so there is that fear that this fear is, we constantly talk about it in practice, and at this point with topical estrogen um, and oral progesterone, there is very, very low risk. It does not cause breast cancer. That has been
Right.
debunked. And I mean, there are risks if you develop breast cancer while you are on it, but that doesn't mean that it caused it. Otherwise, every menstruating woman everywhere would have had cancer by the time they were 50, right? So we have huge amounts of estrogen when we're cycling, and estrogen and progesterone, a really lovely endocrinologist I follow from the US, she has, been very open about how, if thyroid hormone goes low, we fix it. If your
Yeah.
insulin is low, we fix it. If your testosterone and you're a man goes low, we fix it. Why would we not address this deficiency of these major hormones for women as well? Women used to, average age life expectancy for women used to be 55, 60. We didn't live that long past menopause traditionally, and now we live
I was gonna
decades.
I was gonna say, like, here's a fun fact question. All of this suffering and these depletions of these hormones, like, what in nature's way would ever say this is a good thing? But, and in my mind, I was like, women didn't really live that long. So
Oh,
it wouldn't even have been an issue if your life expectancy is around 40 or whatever it was,
yeah.
back in the day.
Yeah.
But
And
now, people are living so much longer and,
yes.
and don't need to be suffering in the way that maybe they once did.
Yeah. Actually, the vaginal. So, one thing that we haven't talked about, which I'm sure some of your listeners have thought about, is what about kidney infections? If patients have these infections that are not being treated, how do we not have all these kidney infections happen? Um, and I just wanted to tell patients that kidney infection rate with an untreated UTI is only about 1.5 to 3%. And it's something that I do see in practice. Patients won't get the diagnosis for many months, and it's very seldom that it goes to the, sometimes it does go to the kidney still eventually after many months, but often, usually it does not. And then
Okay.
just to tie it all in with our current conversation, we actually just got research that shows that vaginal estrogen decreases the risk of sepsis. So that's how impactful it is, right?
Crucial it is.
Yeah, it's saving women's lives. So,
Mm.
I mean, if you have a family member that has had urosepsis as an older adult in menopause, they should be on vaginal estrogen if they want to protect against that happening again. The rate of death from sepsis is very high.
Yes.
So anything we can do to decrease that risk is really, really important. We haven't even talked about antibiotic resistance and the rise of that, which is a global threat. But anything we can do to prevent is much, much more effective than waiting until the infection happens and then treating it afterwards. So, which
Right. Right.
yeah, so estrogen therapy is really near and dear to my heart, just for women. And there's actually new research that's coming out that even says that systemic might be better at improving the vaginal ecosystem compared to vaginal. So,
Really?
no, yeah, so we've got
That's
all this research
interesting.
that says vaginal estrogen is great, reduces UTIs, improves lactobacilli levels, but we're actually starting to get the research that shows systemic. It may even be better at it. So that's very exciting. So if you've ever had someone tell you, "Oh, your systemic estrogen isn't going to help you with your vaginal dryness," that's not correct at all. We actually already know that there is research that shows that systemic estrogen can reduce vaginal dryness by about 75%, but vaginal estrogen is better at it. It's more 90% because we're putting the estrogen right where you need it.
Right where
But
okay,
yeah,
that's
yeah.
interesting. So I guess this has been such a fascinating and such a needed conversation, which you never hear. So I'm really happy to be putting this out there for our listeners because you don't hear talks like this very often. People don't want to talk about this, or they don't want to hear about it. It's like, oh, But here's the thing. So for all women, you may have some kind of urogenital pain and be told, oh, we can't find anything. There's nothing we can do. But now there are other options. There may be something that can be done if there's more investigation, if there's more thorough investigation, if there's
Mhm.
more things known about the biomes in your body that need to be healthy to keep yourself healthy. Like there's so much
Yeah.
now that is known, but it's not it's not known within the medical community. I know that it's not there. They're not there. They're relying on those very old tests
Mhm.
that don't do very much or don't look for very much. That's what they're relying on. The most of the medical system. That's what they've been told. This is the gold standard. That's that urinalysis. This is the gold standard. You won't get better than this. And that's
Oh,
just not the case. That's not the case. Yeah, that old 70-plus-year-old urinalysis is called the gold standard for urine testing. And now you tell us it wasn't even made for urine testing to begin with.
for lower urinary tract. Yeah.
Yeah.
Well, no, actually, this is the second conversation I've had this last week or so. When doctors talk about the standard urine culture, we don't call it the gold standard. The gold standard, when we apply that term to a test, it means we have a high degree of confidence that it's going to give us the correct answer for the condition that we're seeking. So gold standard testing, I mean, like the laparoscopic surgery for endometriosis,
Mm-hmm.
it's it is the gold standard. Often no other testing can identify it 100% of the time unless it's done with a
I
laparoscopic
have heard
surgery.
medical professionals call that urinalysis the gold standard. That's it. That's all. That's if you've got it, it's going to show. If you don't, it's not. And that is not the case. It's just not
No.
the case.
In the
So,
research, we certainly there's actually academics and researchers that have even called out to that test to be abolished. So
yes.
in the academic circles, we do not use the gold standard terminology for this test, and
I'm glad.
and rightly so. The research is very poor, and unfortunately, just I find that it takes a lot of time and a lot of research to convince standards to change here in Canada. So, but they are changing in other places in the world. There's lots of advocacy going around. The Live UTI Free is a great resource for new research that's going on in the world. And I mean, there's Chronic UTI UK organization. There's Chronic UTI Australia. There's lots of organizations that are trying to raise awareness about these issues in order to help things change. Really interesting, the most recent conference in the UK, they talked about lactobacilli bladder instills. So instead of antibiotics, which
Right.
would be really, really,
I
I'd
have
be really
wondered about
interested.
that myself. Like, could you not figure out a way to put the good stuff in there, load that up, and
Mm-hmm.
see what happens? Do some research trials and see what happens in that front.
Yeah.
It makes sense. It makes sense. Gosh, there's just so much to know, and you are so knowledgeable, and we're so glad that you're out there somewhere because so many of us need your medical help. So thank you, and thank you so much for this conversation. I'm so happy to have been able to have this because this is a once in a lifetime thing for me, and what a way to finish off the pain pod with something that is so needed, so underfunded, so under researched, so under everything. But we have to have hope, right?
Yes,
We
we have to
have
have
to
hope.
have hope. We have to have hope that things will get better and we'll find someone somehow, somewhere that will help us feel a little
Yeah.
better.
Thank you
Yeah.
so much for having me on, Anne-Marie. I know we've been planning this for a while, and I'm so glad that I was able to come in as one of your last interviews. And I hope, I wish the best for everybody in the Chronic Pain Canada group. And thank you for your huge contribution to advocacy for helping patients understand their chronic pain better and all the different facets that go along with it. So I just thank you for all the work that you guys have done, and I'm glad that all of the information will be continuing to exist as a resource for patients as well.
Mhm. Best wishes and keep working for us, Dr. Gerard. We need you.
Will
Okay.
do.
Take care. Bye now. Bye bye.
Thanks for tuning in to the Pain Pod. If you enjoyed this episode, be sure to subscribe so you never miss a future show. Share this with your friends, and if you're so inclined, give us that 5-star review and comment. We hope these podcasts motivate you to get involved with us at chronicpaincanada.com. Until next time.